morning, and thank you for staying to the last talk of the day. So I was given the task to summarize important finding from the liver meeting dealing with liver cancer. So these are my disclosure. And I broke the discussion into 5 different areas. What's new in liver cancer therapy? I wouldn't be talking about drugs specifically. I think this is becoming more of an oncology field, but there's been a lot of update, a lot of proof that the drugs actually prolong survival and better efficacy, and we learn more how to deal with them. Then I'm going to be talking about the modifiable factor for HCC, what's new in cancer surveillance, are we doing a better job, update on epidemiology in regard of liver transplant and liver cancer, and precision medicine, we're getting closer and closer to it. So let's start with HCC therapy. This is a study from UT Southwestern where Dr. Rich and her colleague looked at factors that could predict racial and ethnic reason why certain people receive curative treatment for early stage HCC and why some don't. So they looked at 744 patients with early stage HCC. They interrogated 2 hospital systems between 2008 and 2021. And as I mentioned, their goal was to identify barrier for patients receiving curative treatment. And they defined the curative therapy as patient receiving resection, liver transplantation, or ablative therapy. Their cohort was actually similar to what we see in our clinic, mainly men. White ethnicity was dominant with 39%. Black and Hispanic follow closely after with 26 and 28%. Majority of the patients were child-age cirrhosis. What they found is 59% of the patients received curative therapy, with resection accounting to the majority, 37%. That's following the guideline, compensated cirrhosis. And the transplant was offered 29% and ablation at 34%. But when they look about the ethnicity and the chance of getting curative therapy, white people were more advantaged, with 64% of them receiving curative therapy compared to 54 to 56% in Hispanic and Blacks. Then they did an elegant analysis. They looked at reason for not receiving therapy, resection, transplant, or ablation. And actually, it's quite surprising. Liver dysfunction was the main reason in white and Hispanic compared to Black. Comorbidities were more common in Blacks compared to white and less common in Hispanic. But tumor burden was actually more prominent as a reason for not offering curative therapy in Blacks compared to white and Hispanic. And another finding, they found that Black people tend to present with higher advanced stage of HCC. 17% of them actually had the rapid progression of their disease during the duration of the study. And when they adjusted for other covariates like age, gender, cause of liver disease, or tumor burden, or Child-Pugh score, these findings persist. Black people were 39% less likely to receive a curative therapy, and Hispanic 35%. So there's a lot of disparity in offering curative therapy for patients depending on their ethnicity according to the study. And more studies are being done to identify factors that will lead to improvement and equality. Another study presented by Dr. Yang's group, Dr. Yeo and his colleague, they looked at the outcome of patients receiving immunotherapy, checkpoint inhibitor, PD-1, PD-L1 therapy, and versus people who received immunotherapy first, followed by radioembolization. So they interrogated the National Cancer Database between 2017 and 2019. And this is a database actually that have a lot of accuracy in identifying patients with cancer and their outcome documented. 1,725 patients were identified with stage 3 and 4 liver cancer. And they defined receiving immunotherapy, they required receiving immunotherapy as first line of treatment. And the duration between immunotherapy and TER must be less than 90 days. So in their cohort, they found 1,500 patients who received immunotherapy alone and 200 patients who received combination therapy. So what were their findings? If you look at the blue box at the bottom, you could see that people who received immunotherapy alone were disadvantaged in terms of survival compared to people who received combination therapy. Survival is 21.7 months versus 9.5 months. Then if you look at where the patient received treatment, you could see patients who were at an academic center were more often to receive combination therapy compared to patients who received therapy in non-academic center. And of course, patients who had insurance were more likely to be offered combination therapy. Now, if you look at the graph on the right, you can see two lines, red and blue. So the red is the one who received combination therapy, and the blue, the one who received immunotherapy by itself. And you can see there's a different survival advantage. There's a 50% more likelihood that lower mortality risk in patients receiving combination therapy compared to immunotherapy. And I think this study is going to revolutionize the way we look at treatment for liver cancer in the future. And I think more follow-up study will follow for this. Another study that kind of dear subject to my heart is for hepatitis B and HCC. And Dr. Mindy Nguyen from Stanford and her group interrogated the Optum database. So depending on ICD code, a patient with hepatitis B, HCC diagnosis, and they compared them to their pharmacy prescription to see how many patients were actually receiving hepatitis B therapy. So the cohort, about 2,000 patients, 71% male, mean age 63 years, 40% Asian, but more important, 72% of them had cirrhosis. So these patients, according to the guideline, need to be on hepatitis B therapy, especially if they have HCC. So they're finding only a third of the patients received hepatitis B therapy. So we still need a lot of work to do to educate practitioners about the importance of treating hepatitis B, especially if HCC patient has combined HCC and hepatitis B. Then they tried to compare treatment era between before 2010 and after 2010. And actually, we did a better job. Before, we used to treat 26% of the patient, but now we're up to 40%, but that's not enough in my opinion. And if you look at the graph just above it, with a dark gray, only 50% of patients with compensated cirrhosis were on hepatitis B, and even scarier, only 30% of the patients with decompensated cirrhosis were actually on hepatitis B therapy. Now, if you look at the ethnicity and race distribution, you could see white, black, and Hispanic were disadvantaged compared to Asian about being offered the HBV therapy. So 51% in Asian compared to less than 35% for other ethnicity. And now they looked also at who gave the prescription, where the patient was seen. So as expected, if you were seen by a GI or ID group, you were more likely to be offered hepatitis B therapy in the setting of HCC and hepatitis B, but that number is only 42%. So we still have more work to do to increase that number close to over 90%. Then they did a multivariate analysis, and Asian patients, as I mentioned, were more advantaged to receive hepatitis B therapy, 3.5 times more likely, with an OR ratio of 3.57. And the other findings they found, people who received the hepatitis B therapy in a setting or HCC, they had the survival advantage, 24% to 26% survival advantage. So moving to modifiable factor for HCC. So this is actually a study that got my attention and a lot of attention at the liver meeting. This is an analysis of the Women Health Initiative study. They followed postmenopausal women for 19 years, and they tried to look at the effect of sugar-sweetened beverages intake, so sodas, fruit juice, energy drinks, etc., to see if they on impact on incidence risk. And in their studies, they excluded the patient who developed liver cancer within 2 to 5 years of study enrollment or analysis. So what they found, patients who received sugar-sweetened beverages, they have 85% more chance of developing HCC during the duration of the study from 1993 to 2020. And they tried to break it down, whether it's soft drinks, the fruit drinks, or the artificial sweetened beverages. Even though the confidence interval crossed 1, it was a trend that the patient who have soft drinks or fruit drinks, there were a higher rate or higher chance of developing liver cancer. So this is similar to prior study from 6 years ago that kind of repeats the same message. Sugars and might be a risk factor for liver cancer. When they looked at the artificial sweetened beverages, then there was no correlation. So in summary, sugar sweetened beverages is a potential risk factor for liver cancer in postmenopausal women, and I think that's going to be linked to insulin resistance with time, and we're learning more and more about NAFLD and increased risk of HCC, and that could be one proving study to that risk. And this is a reminder that statin use has been linked to risk reduction in HCC, and Dr. Gish mentioned this study in his presentation yesterday, and we're learning more and more. It's actually the kind of statin that's important. Lipophilic statin have a more association with decreased risk of HCC. At Cedars, we just finished the multi-center NIH studies looking at this question. The study just finished, and now we're analyzing the data, and it will be the first placebo-controlled study looking at the effect of simvastatin, the drug we chose, in reducing the risk of HCC. But from other studies and data meta-analysis, this is valid. There is a 2 to 5-fold decreased risk of HCC in patients with cirrhosis who are on statin. Now, how about diabetes? The new kid on the block. So this is another elegant study from the VA, a retrospective cohort study of 82,000 patients. 58% of them were diabetic, followed for a mean of 5 years. And during the study, there was 8,000 incident HCC. So the primary goal of the study was to find the relationship between diabetes and onset of HCC. So the factors, the variables they studied is the duration of diabetes mellitus, how long the patient was maintained with the A1C less than 7, and how long it took the patient to reach that goal of A1C less than 7, first 2 years or more than 2 years. So what they found. So this is their cohort first. So there was 58% of the patient have diabetes, and the etiology of diabetes was cirrhosis were mixed, alcohol, Hep C, NAFLD, etc. Most of the patients had a Child-Pugh score A, so more on the compensated, and race and ethnic distribution was similar to what's been reported in the literature. So this is the finding of the study. So patients who were diabetic has a 22% increased risk of developing HCC with time. The other factors from the studies that they looked at, similar to what we know, if you have alcohol, HCC, HCV, HBV, you have a higher risk of developing liver cancer. But when they look at diabetes and certain etiology of liver disease, diabetes and NAFLD and alcohol, Hep C and Hep B, they found actually diabetes in the setting of NAFLD, that risk is even higher, 41% higher risk of developing liver cancer. Kind of trumps the alcohol, 37%, and hepatitis C and hepatitis B. It was hepatitis B being the highest, 57%. So this is kind of another message that we need to pay closer attention to our cirrhotic patient with diabetes and metabolic syndrome, and they are a higher risk to developing liver cancer. And some experts will even take this even further to screen for a patient with F3 for HCC at an earlier stage. Now, how about duration of diabetes? So each year the patient is diabetic, they have a 19% chance higher risk of developing of HCC from their study. And then if they achieved the control of their diabetes, they brought their A1C to less than 7 more than 2 years, that risk is even higher, 2-fold higher compared to other group. There was a surprising finding in their study in patients who achieved control of diabetes less than 2 years. They were actually at a higher risk for liver cancer compared to uncontrolled. But actually, during the oral presentation, Dr. Mezzacapa eloquently elucidated that patients with advanced cirrhosis, they tend to have a lower hemoglobin A1C. So lower hemoglobin, so their A1C tend to be actually lower than people with early stage A1C. The other important factor, insulin by itself, is carcinogenic factor. So there's a higher incidence of liver cancer with people on insulin too. And sulfonylurea, so glypyride have been also associated with a higher risk of liver cancer. Now, another study that also was mentioned briefly, it's the importance of treating low level of viremia in patients with HCC and hepatitis B. So this is a Korean study, 600 patients. They followed patient for 10 years, and important, this patient has less than 2,000 IU per ml of hepatitis B PCR. And they found people who had viral suppression, they have a lower rate of liver cancer. So the hazard ratio for patients who were not suppressed was 2.16. So we need to do a better job. HCV surveillance. Now, this is just a reminder for our patient with hepatitis C who were treated with DAA, the risk for liver cancer persists. So this study tried to identify a patient that you should trigger your reaction to screen them for HCC more carefully. And what they found when their AFP crossed 20, even one time post-DAA within 2 years, the first 2 years after therapy, these patients have a 14-fold higher risk of developing HCC afterward. So it's kind of interesting study. One-time measure of AFP over 20, higher risk of liver cancer. And this is also another important study looking at what to do with patients with liver lesion less than 1 centimeter. So the guideline recommend doing a short imaging study within 3 to 6 months, either with contrast imaging. So what been done actually in the community? So this is they looked at over 800 patients, and what they found actually, patient with one lesion, despite having cirrhosis, only 25% of them were getting imaging within 1 year, not just 3 to 6 months. So just imagine you have 25% of the patient not getting any imaging for a whole year. The patient who were following the guideline, only a third of them. So we still have a lot to do in that regard. And then what in that study they found other factors linked to high risk of developing liver cancer, patient with advanced cirrhosis, lower platelet count, Child-Pugh score, etc. So we just need to do a better job to follow these patients. Just one study on epidemiology about NASH. So Dr. Yunusi presented the oral presentation from SRTR analysis. And what he found over time, between 2012 and 2021, the incidence of NASH has been increasing as a leading risk for liver transplantation from 10% to 28%. And what found, this is actually it's an important slide. So if you look on the left, these are patients without HCC who are currently being listed on the transplant list. The leading cause for listing is actually alcohol. But if you look at patients with HCC, you could see the proportion of patients with fatty livers, the red bars, is actually widening. So it went from 10% in the early 2012 to almost 30% in 2021. So NASH is now actually the #1 cause, leading liver disease cause of being on the liver transplant list among patients with HCC. And if you compare it to other etiology, you could see the orange color. This is hepatitis C. The rate is decreasing in patients with HCC, but NASH is increasing. The gray, followed by alcohol, and hepatitis B is stagnant. Finally, Judong already mentioned this, so I'm not going to dwell too much. There's a lot of developing in liquid biopsy, trying to detect liver cancer through a serum blood. So this is one example from Dr. Amit Singhal. It's a novel liquid biopsy assays he's developing, looking at metalloprotease. So metalloprotease are a protein detected in the serum around inflammation and liver cancer formation. So they isolated these certain number of these metalloprotease and develop an assay. And as you could see on the right, the AUC is 0.883. So that looks like a promising test, and we will be looking forward to hear more about development. This is another study, actually, it was elegant. They compared patients with different etiology of liver disease who developed cancer. And they looked at their serum and they analyzed, and they found certain cytokines tend to be elevated in the setting of liver cancer, regardless of liver etiology. So there is more assay being developed, and I think it's going to be a combination of different approach trying to perfect that liquid biopsy. And this is my last study I'm going to discuss. So these are a group of patients that received treatment for liver cancer TACE in this setting, and they got a liver biopsy, and they looked at the microenvironment around the liver cancer. And what they found is actually there's a different interaction between the immune cell and the liver cancer that lead to immunosuppressive environment for the liver cancer detection. You know, all of these patients, I forgot to mention, they have residual cancer on their biopsy. So this is another study. I think it will also kind of build on what Dr. Yang's study showing that radioembolization, immunotherapy are needed as a combination therapy. And this study aimed to identify the subgroup of population that will benefit from adding further therapy and refining the immunotherapy choice. So in summary, we still have a disparity in access to hepatitis C treatment between comparing white, Hispanic, and Blacks. Diabetes now is recognized more and more as one of the major risk factors for liver cancer. Sugar and sweetened beverages is now being quote unquote validated as a risk factor. NASH is now becoming the main indication for liver transplantation in patients with HCC. We're getting closer to having precision medicine for patients with HCC, and we know more, and we're still learning about the importance of the microenvironment of HCC and the interaction with the immune system, and that better understanding will help us tailor better choice for HCC therapy. So I hope I brought you back on time, Paul. Spoke too fast. Thank you.